Hello everyone, I'm Lyuba, I'm a data scientist. I work with Antonia in Oxford. And today I'm going to talk to you more about Oxford data and not only Oxford data. But first I'm going to ask you to imagine a kind of regular labour. So imagine a woman that is 36 years old, giving birth in 2018. So for the purposes of this talk, I'm going to talk about single-term pregnancies that are CTG monitored, so in some sense are considered higher risk in order to be CTG monitored. And in 2018, a pregnancy in a labour like that, what did that mean? So the mum was probably a little bit overweight, and that just tracks general demographic statistics of increasing BMI. She had about a 1 in 8 chance of having either gestational or usually gestational, sometimes type 2 diabetes, but was very unlikely to have preeclampsia, for example. So that is what a regular case might look like. And then when she goes into labour, she has about 1 in 3 chances of being induced, and about 1 in 5 of having an unplanned C-section. So we're taking the planned C-sections out. This is, for example, something worrying was seen in the CTG trace, and then they advised a C-section. And the baby, as we heard earlier from Austin as well, is overwhelmingly, most babies are perfectly healthy and fine. About 1 in 40 might have a low APGAR score, 1 in 3 minutes. And then only about 1 in 200 will have a severe outcome from labour. And if you think about kind of that same 36-year-old woman giving birth and take her 20 years in the past, in 1998, a case like that might look a little bit different. So she's probably no longer or was less likely to be overweight, so she probably has a healthy BMI. And in our data set in Oxford, not one of these women had diabetes diagnosed, and you can choose to believe whether that meant that none of them had diabetes or that we had some missed cases. However, rates of preeclampsia, for example, were much larger, much more common. 1 in 7 would have had preeclampsia. Labour actually looked much the same way. About 1 in 3 were induced, about 1 in 5 had an unplanned C-section. But overall outcomes were worse. So low APGARs were more common, and severe compromises were much more common. And the reasons for that, there are several reasons for that, right? One of them is that demographics change. So things like diabetes rates and obesity rates are obviously a function of demographics as well as diagnosis, but also clinical practice has changed. So earlier I told you we were thinking about these at high risk CTG monitored labours. But what counts as at high risk CTG monitored labour has changed significantly. So the women who were CTG monitored in the past were maybe a higher risk group than the women who are CTG monitored nowadays. And that, even if the actual kind of care is more or less the same, has an effect on the outcomes and outcome rates. And the reason I'm telling you all of this is because I've been thinking a lot about how maternity data has been changing over the years and how it changes across different hospitals in England. So part of what I've been doing with the Oxford Labour Monitoring is looking after this data set that combines delivery information across our hospital in Oxford that you heard Joanna talk about, as well as 2 other hospitals, the Rosie in Cambridge and St George's in London. So currently we have about 225,000 records, of which in Oxford we have some that are CTG monitored and some that are not. And in Cambridge and St George's we have the CTG monitored records. And for each of those we have a different number of clinical variables that were recorded. So that would be maternal and kind of information about the pregnancy, then information about the labour, and then information about what happened to the baby afterwards. And that data was actually stored over time, has been stored in different formats, right? So in Oxford we've undergone several different software changes, big software changes that impact the way that the data is recorded. Cambridge used a completely separate system, and in St George's we were working from nodes that were digitized, so it's a lot of free-form text that we've extracted information from. And what that means is that the data can vary in all of these ways that are quite technical, that have nothing to do with care, but actually have to do with like, oh, well, how was this written down, right? So, for example, how good are we at distinguishing between different types of diabetes? Or how good are we distinguishing between preeclampsia and pregnancy-induced hypertension? Not because that was not correctly recorded and diagnosed at the time, but because of what the data record looks like afterwards. So I've spent a bit of time kind of trying to integrate all of this data together to make it as a sort of comparable across the data sets as possible and as accurate as possible. And Joanna already talked about how one thinks about doing that, right? And how we think about making sure that all of our data is recorded to the same standard, and kind of where and how our data missingness is. And then what that allows us to do is it allows us to see how data has changed over time. So I'm going to show you a little bit of that. So one thing that we all know is that mothers and parents in general are getting older and older. And we see that very clearly so in St. George's we don't have maternal age, but across the data from Oxford and Cambridge. And that tracks perfectly actually with the Office of National Statistics, information about first-time parents. And kind of how we've gone from an age of kind of maybe about 27 and a half at the time of a first-time pregnancy to just over 30 years of age over the last 30 years. So that's kind of quite encouraging. So we can see trends that we expect to see in the data. We also see some trends that we don't necessarily expect to see in the data looking at national statistics. So one thing that we know is that we have increased rates of C-sections, and that's true for both planned C-sections, which I'm not showing you here, and the unplanned ones that I talked about earlier. And you can see that in Oxford, and you can see that in Cambridge in yellow. And one thing that you can see across the two is that there's clearly a difference in the clinical practice across the two hospitals, right? Even though both rates are kind of increasing. They are very separate, different to each other. And in St. George's, you see something slightly different. Actually, you see very high rates of C-sections that have since dropped. And that again has to do with their kind of who gets counted as high risk. So in these first few years, there were far fewer and much more serious cases of CTG monitored deliveries, and that's why we see a much higher rate, as well as a general change in clinical practice and how these labours are managed. So there's kind of, when that's important to me thinking about risk assessment and machine learning methods, because often we try and think about C-section as an outcome variable when we don't have, especially if we don't have good data on the labour outcome. And it's sort of really important to remember that that's a function of two things. So that's a function of the kind of clinical need, but also in the standard of care. And kind of in when that data was collected, who collected it, what was the population that was being served. And can differ an awful lot from hospital to hospital. It's not the same everywhere. And finally, something that's kind of quite close to my heart. So I told you earlier about increasing BMIs and rates of diabetes. So what you see on the left-hand side of the picture here is an increase in the diabetes rates, diagnosed diabetes. So this is all diabetes together. And even though these three hospitals actually diagnose diabetes, gestational diabetes slightly differently, their rates match. They also match national statistics. So about, as I told you, about 1 in 8, 1 in 9 women nowadays in labour will have gestational diabetes. And that's important because, as Austin said earlier, it makes babies larger. And when we think about, so that's what you see on the right at the top, you have the diabetes, and at the bottom you have BMI. In red, you have the small for gestational age babies, so that's bottom third percentile of birth weight. And at the top, and in blue, you see the large ones. And we have more and more large babies being born every year. And that is in part because of these increasing rates of diabetes and also increasing rates of high BMI. And that's important risk-wise because we know that while a lot of our risk mitigation is rightfully targeted at spotting fetal growth restriction and complications that are associated with fetal growth restriction, we have these large babies that are a slightly different risk group. And we need to watch out for them as well. And they're going to be an increasing proportion of our risk, our pregnancy or labours at risk. And we still kind of have to think about like how much do we need to worry about these as well, because we still know that the overwhelming majority of babies are completely fine. When I say completely fine, so earlier I mentioned these rates of kind of severe compromise at birth, which is a compound definition that we work with in our team, that is a combination of brain injury, as well as neonatal death in stillbirth, need to resuscitate the baby, and for it to spend time in NICU afterwards, and so on. And we see that those rates in Oxford have fallen quite dramatically in the early 90s with the introduction of induction for post-term pregnancies mostly, and if they stayed relatively flat. And they stay relatively flat across all 3 hospitals. And they vary so much, again, because we're talking about, so this is a combination outcome of several very, very rare outcomes. And so how accurately we can detect these is, again, kind of a function of like how good are we at picking up the relevant information from the data, and that's quite a hard problem to think about, just because the patient records vary so much. And kind of what I want that to leave you with overall as an impression is that it's quite difficult to compare apples and oranges when we think about comparing data that comes from different hospitals, or even kind of maybe a decade and a half apart in the same hospital. And that's because the demographic of the women who, and people who give birth changes, but also because clinical practice changes and differs across hospitals. And then we have to ask ourselves, when we think about risk in labour, do the risk factors all remain the same? And kind of one answer to that is yes, because physiology is physiology. Diabetes is always going to be dangerous. Preeclampsia is always going to be dangerous in some sense. But how we quantify that may differ a little bit from hospital to hospital. And we have to, again, keep into account the fact that we do have new challenges that come with this changing demographic and the different clinical conditions that that demographic may present with, but also we are better at solving older challenges. And when that comes to, when we think about kind of risk prediction and machine learning tools for risk prediction in labour, we have to kind of keep in mind that what we are trying to predict for is population nowadays in the hospital that tool we hope is going to be employed, rather than some information about another hospital 20 years ago. And some kind of thoughts on how one might go about validating a risk assessment tool that was built using large data sets like this. It's really, really important to always validate on new and external data sets, I think, partly because the data sets differ so much. And do the thing that we already tend to do in machine learning, which is think about ranking. So think about actually not quantifying the exact risk, is it sort of 0.4, 0.5, and what do those numbers mean, but actually can we say how much, what the relative risk of someone is compared to their general population, say in that hospital. And importantly, and perhaps hopefully a bit more simply, can we accurately identify lowest risk labour so that we mitigate from over-medicalization of labour where that's not necessary, which also means that we can target monitoring and care where it's really needed. So I'll leave you at that. Thank you very much to the whole OLM team, as well as various clinical collaborators. Thank you.